All right, welcome to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day. We're coming off a stretch of shifts. Actually had an interesting case, very classical, even though most patients don't fit the usual textbook. And it was elderly female. I guess unique features were that she was not on any immunosuppressive therapy or had immunocompromising conditions. That'll be relevant later. And she came in with that refractory pneumonia. Saw her PCP a couple weeks ago, got antibiotics, didn't get better, came into the hospital. Got broad spectrum antibiotics, still didn't get better, and actually ended up needing the intensive care unit where she had to get intubated. She got ARDS, proning the whole gambit. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. She had like 2 subtle skin lesions that looked really classical for actually blastomycosis, and lo and behold, both blood tests and biopsies of the lesion, she actually had disseminated blastomycosis, so got her on the appropriate therapies now, and hopefully will be doing a little bit better. But nonetheless, that refractory pneumonia, that's failing all these antibiotics, good thorough exam, I'm sure our infectious disease colleagues would agree, can sometimes reveal something that you maybe weren't expecting, especially in someone like her who is an immunocompromised and all that jazz. But anyway, today we're going to be talking about beta blocker overdoses. Didn't see any of those on our stretch of shifts, which is probably a good thing. But we're going to go into beta blocker overdoses today. What are beta blockers? We'll talk about classes and properties, formulations. We'll talk about the epidemiology of beta blocker toxicity, mechanism of toxicity, clinical presentation, diagnostic workup, initial ED and ICU management algorithm, including pharmacotherapies to treat it. We'll talk about kind of advanced therapies for it as well, some adjunctive therapies, some kind of advanced hemodynamic therapies, how to monitor, what the prognosis is, and then we'll do a little practice questions at the end. This study guide will be updated on our Patreon page as is usual, so we'd love for you to check that out if you have an interest in getting the study guide. And no further ado, beta blocker toxicity. So most people know this, but we're going to start by what are beta blockers. So beta blockers are commonly prescribed medications. Indications that they're used for are hypertension, ischemic heart disease, arrhythmias, heart failure, migraines at times, essential tremors, thyrotoxicosis. So lots of indications. Most primarily is probably for hypertension, ischemic heart disease, arrhythmias, and heart failure. Those are probably going to be the majority of indications that you see. But lots of patients are on beta blockers, right? Metoprolol, atenolol, carvedilol, all these are beta blockers. There are slightly different classes and properties to beta blockers. So there's the cardioselective beta blockers. These are beta blockers that primarily work on the heart, the beta-1 receptor, hence cardioselective. And these are things like metoprolol, atenolol, and bisoprolol. These are all cardiac selective. And then there's non-selective beta blockers, which work on the beta-1 and beta-2 receptors. So they're not just selective for the heart. And these are things like propranolol, natalol, and timolol. And then there's some beta blockers that actually have mixed effects, alpha and beta receptors. This can cause some vasodilation from the alpha blockade. And these are things like labetalol and carvedilol. All right, so there's some mixed classes and actions of these beta blockers, and this can become significant in toxicity, although the selectivity is dose-dependent. So in significant toxicities, you sometimes lose this dose-dependent receptor selectivity, and you'll get beta-1, beta-2, alpha, all that kind of stuff. If we're talking about beta blockers, they do a couple different things. Obviously, they'll block these receptors and they can slow down the heart rate and they can optimize myocardial oxygen demand and all that good stuff. But they also have a couple other effects too, and these effects become relevant in toxicity. So one of these is intrinsic sympathomimetic activity. And this essentially means that they may produce less bradycardia in overdose. And these are things like acebutolol and pindolol. These are not common, at least not in the States. I don't know about other places, but just know that they exist. There's membrane stabilizing activity of beta blockers too. The sodium channel blockade, which will become relevant in toxicity as well. And beta blockers that have more of this effect are things like propranolol, again, acebutolol, and bitexolol. Propranolol is used. Again, we don't see acebutolol or bitexolol very often, but this can lead in toxicity to QRS widening and ventricular arrhythmias because of that sodium channel blockade. Again, we'll talk more about it. And then do note that they're lipophilic. Many of them are, at least. And lipophilic means they're fat-loving, which means it can cross the blood-brain barrier and cause CNS toxicity. Focus on propranolol. You can start to see propranolol's got a lot of these properties that can be dangerous in toxic doses. Metoprolol, which is a very common beta blocker, and carvedilol. So we'll be coming back to these classes and properties as we go through this discussion, because again, this is going to become relevant for some of the symptoms and things we have to do to manage them. As with any toxicity, formulation is incredibly important. You know, we've talked about a couple different toxicity pathodromes, and we have a whole playlist on kind of toxidromes. And for any of you that have seen those, formulation is incredibly important because immediate release is going to act different than extended or delayed release. And the timeline is quite important in these cases, right? If it's immediate release, you're going to have peak absorption of what you took at a certain time, where if it's extended release or delayed release, you might have a much more prolonged toxic period rather than kind of the more expected timeline in someone who took immediate release. So why does this matter? Why are we talking about beta blocker overdose? Well, beta blocker overdose can cause patients to get incredibly ill. This is one of those overdoses that, makes you really, really nervous when you're in the clinical arena, me included, because you can get this rapid cardiovascular collapse, you can get neurotoxicity, and you need to really intervene aggressively and quickly, right? Consider early decontamination, trial something like glucagon, high intensity insulin, vasopressors, bicarb, lipid emulsions, even ECMO, right? All things we'll talk about as we go through this discussion. Okay, epidemiology, just quick. How often does this happen? Well, beta blockers are obviously common among cardiovascular drug overdoses. Propranolol is frequently implicated in severe CNS toxic cases, right? Because as we said, propranolol is lipophilic, it's fat-loving, so it crosses the blood-brain barrier. Mortality increases in these patients with delayed recognition, extended release formulations, co-ingestions. This is one of those other things that for any toxidrome, you need to always think about and ask about co-ingestions because they will affect, 1, the symptoms you're having, 2, how to manage them, and 3, sometimes the absorption of the drug too. And then, so mortality increases with delayed recognition, extended release formulations, co-ingestions, and then any lipophilic or membrane stabilizing agents, right? Lipophilic being crosses the CNS, crosses the blood-brain barrier into the CNS, and MSA agents, things like sodium blockade, which can cause QRS widening and significant arrhythmias. So mechanism of toxicity. Mechanism is important because this will then drive symptoms. So if you understand mechanism, you then can extrapolate and understand symptoms. And as we talked about, beta blockers have beta 1 blockade action, beta 2 blockade action. Some of them have sodium channel blockade action. Some are lipophilic, and then we're going to talk a little bit about a specific beta blocker, sotalol. But beta 1 blockade, beta 1 receptors are in the heart. Right? If anyone saw any of our vasopressor episodes, we talked a lot about the different receptors in the heart and peripheral vasculature. But beta 1 receptors are in the heart, so when you block them, you're going to cause negative inotropy. Inotropy being how good the heart is pumping out blood, how good it's squeezing. So that's going to go down. Negative chronotropy, which is heart rate. So we'll write inotropy is squeeze, chronotropy is heart rate. So both of those are going to go down. And as one can imagine, then you're going to get bradycardic, or low heart rate, you're going to get hypotensive, you can get AV blocks, and you can go into cardiogenic shock. Really serious stuff. Beta blockers, though, if they're non-selective, or even if they're cardioselective and you take high doses, can also have beta 2 blocking effects. All right, and this can cause peripheral vasoconstriction constriction, bronchospasms, and hypoglycemia. We have an episode out on calcium channel blockers, and one of the big challenges is differentiating beta blockade from calcium channel blockade. And the glucose can be quite helpful because in calcium channel blockade, if anyone watched that episode or listened to it, you actually get hyperglycemia. And in the clinical arena, does this always happen? No, but textbook answers and test questions, calcium channel blockers, you'll have hyperglycemia. Beta blockers, you'll have hypoglycemia because you get decrease in glycogenolysis and gluconeogenesis. This is especially common in children. We mentioned that beta blockers can have some sodium channel blockade, and that's going to cause QRS widening. It can cause ventricular arrhythmias. More common with propranolol. Beta blockers that are lipophilic get into the CNS, into the brain, and can cause CNS depression, seizures. Again, propranolol is a big guilty drug for this one, but metoprolol and carvedilol, which are two common ones, can also do this. All right, so you can get some CNS depression, seizures. And then sotalol is non-selective, but it also has this class 3 effect. We've talked about sotalol. We have a whole series on antiarrhythmics, so definitely check that out if you're interested. But sotalol can cause torsades through its QT prolonging pathway. So if we think about the mechanism of toxicity, the 4 main things to think about are beta-1 blockade, beta-2 blockade, sodium channel blockade, and lipophilicity. All right, and beta-1 blockade, you're going to get bradycardia, hypotension, AV blocks, cardiogenic shock. Beta-2 blockade, you're going to get bronchospasm, hypoglycemia. Sodium channel blockade, you're going to get QRS widening, you get ventricular arrhythmias. And if it's a lipophilic beta blocker, it gets into the brain and causes CNS depression, seizures, all that good stuff. So this is then going to translate into clinical presentation. And we break it down by system here: cardiac, neurologic, respiratory, metabolic, and then timeline. So as we mentioned, cardiac, you're going to get beta-1 blockade. So you're going to get sinus bradycardia. You're going to get junctional rhythms, AV blocking rhythms. You get hypotension and shock. And then if it's a sodium channel blocking agent, you can get ventricular dysrhythmias. And if it's sotalol, you can get torsades. Okay? Neurologic effects. If it's lipophilic, remember propranolol is a big guilty lipophilic one, as well as metoprolol and carvedilol, which are two common ones. All of these are lipophilic. All of these can get in the brain. So you can get lethargy, coma, seizures, specifically. Respiratory, we also mentioned that beta blockers have beta-2 effects, especially at higher doses, even if they're cardioselective, and then cause bronchospasm. It can even cause apnea. Beta-2 doesn't cause apnea. CNS depression can cause apnea, but you can get bad bronchospasm with the beta-2 blocking effect. Metabolic, remember, hypoglycemia. Calcium channel blockers, hyperglycemia, metabolic hypoglycemia, and you can get a lactic acidosis. The timeline here, remember, is it extended release or is it delayed onset? If it's extended release, the timeline is usually 1 to 2 hours. If it's, did we say that right? If it is immediate release, the timeline is often 1 to 2 hours. If it's extended release, you might have delayed onset, 6 hours, 12 hours plus, sometimes even 24 hours, depending on if there's co-ingestants and things. So immediate release, 1 to 2 hours. Delayed or extended release is just going to be much longer, greater than 6 hours, maybe approaching 24 hours. All right, diagnostic workup. Well, obviously you want these patients to be on continuous cardiac monitoring or telemetry. You want frequent vital signs depending on how bad the ingestion is. You want to get a basic metabolic panel. You need glucoses, right, because you can get hypoglycemia. All this is adding up. As long as we know the mechanism of toxicity, we can extrapolate symptoms and workup. You want to get LFTs, troponin, mag, phos, ABG, VBG, lactate, all that good stuff. You certainly want an EKG, looking for QRS widening, QT prolongation, all that. And then these patients go into cardiogenic shock. So you want to get a chest x-ray. You want to maybe POCUS some, think about pulmonary edema, look to see how their heart's doing, all that good stuff. All right, initial ED and ICU management. Well, with any initial ED or ICU management, step 1 is always going to be stabilize. Do they need to be intubated for severe altered mental status, seizures? Are they protecting their airway? Get some large bore IVs in them. Consider an arterial line. If it's a massive ingestion, low threshold to put an arterial line in, even a central line, right? Especially if the patient's in shock, because these patients most likely are going to keep getting worse if they had presented close after their overdose, rather than better initially. And then treat hypoglycemia. Check a glucose right away. So airway, breathing, circulation, glucose. Recheck frequently if it's low. Decontamination. if this is a really, really recent overdose, they come in within an hour of taking their beta blocker, maybe even 4 hours if it's extended release, you can give activated charcoal, right? This can cause patients to have a lot of GI issues, and as such, airway protection is important to note, because the last thing you want is for to give them activated charcoal and then they aspirate and it causes all sorts of issues. People talk about whole bowel irrigation. This is not something that we have classically done. So with all of this, we should have said this even earlier, call Poison Center. And you can Google the number in your area. They are an incredible resource. These patients are very sick. Call your Poison Center. They will help you out. All right, first line pharmacologic measures. Well, if it's symptomatic bradycardia, you can give a dose of atropine, but this is just going to be transient, right? It might not even be effective at all, and this should not delay definitive therapy. So if you want to give a dose of atropine, go for it, but you shouldn't be sitting there banking that the atropine is going to actually be effective or sustained, because it won't be. You can trial glucagon. Realistically, you probably should trial glucagon. This is a bolus usually. If there's no response, you can consider repeating it. You could even do infusions, but this causes a lot of emesis, a lot of vomiting. So really, really, really consider pre-medicating with an antiemetic, and just know they're probably going to vomit. So if you got a patient whose mental status isn't great, they're not intubated, just give them a bunch of glucagon, they might puke and aspirate. So just be really careful with that. Calcium is something people talk about. This is a mainstay of treatment for calcium channel blocker overdose, but the evidence in beta blocker is not super robust. You can try giving it to see if it helps folks. It is kind of like nature's vasopressor inotropes. You might get a little inotropy from the calcium, but much more center stage for calcium channel blocker overdoses. And then, vasopressors and inotropes, are they hypotensive and shock? Do they have low contractility, low inotropy? Are they in cardiogenic shock? Think about epinephrine. Epinephrine has beta 1, beta 2, and alpha effects, so it'll start to overcome some of that beta blockade. Norepinephrine has alpha more than beta effects, so it has less effect on the heart, less kind of increased inotropy and all that. Dopamine is not something we recommend using, although people talk about it. We don't commonly use this, but isoproterenol can increase the heart rate, but it can cause some arrhythmias and hypotension. So, again, we don't classically use it. Really, epinephrine is a great drug in this situation, just because it has both that beta effect as well as that alpha effect. Again, if I'm speaking French and you don't speak French, if this sounds like French to you, check out our vasopressor episodes, because those will provide a lot of context on the different receptors of the different vasopressors. And you can find that on our page, or linked probably in the description of the episode and all that. We got it all over, so just hop on our page and check it out. Okay, advanced therapies. This is where things get a little complex. Just like calcium channel blockers, if you watch that episode or listen to it, high-dose insulin euglycemic therapy is really a central management option for these patients who are getting sicker. And what is literally happening is you're giving high-dose insulin, and the heart then can utilize carbohydrates. It's kind of like turbocharged, and it will cause an increase in contractility for those patients that have failed pressors and glucagon and all that kind of stuff. But notice this is high dose insulin. So this is not medical advice. Please, don't act on this as if it is medical advice. We got disclaimers all over the place. So don't act on these doses or any of that. But just for context, usually this involves a bolus of around 1 unit per kilogram of insulin. That's a ton of insulin, right? Someone's 100 kilos. That is 100 units of insulin bolused. So these patients are going to get hypoglycemic. And we already might be battling hypoglycemia. So you got to give these patients tons of dextrose. Do it ahead of time. Don't be reactionary. People can die from hypoglycemia. So this is really serious. But this is a therapy that you probably will need to do. So you have to be very, very thoughtful in glucose management when you're starting this high dose insulin, because you're going to start then an infusion. This infusion is can be as high as 10 units per kilogram per hour. But usually you start at 0.5 to 1 units per kilogram per hour. So this is a very dangerous therapy, but one that can save a patient's life too. And you can do it safely. You just have to be very strategic in your glucose checks, making sure you're giving them extra dextrose as needed and really watching for hypoglycemia. The other thing here is potassium. Insulin shifts potassium intracellularly. So you have to monitor potassium, and if that potassium drops less than 3.5, we would even keep it closer to 4 to 5. If it drops less than 3.5, you really maybe should, depending on the clinical scenario, consider stopping the insulin for a little bit, because someone can obviously die of hypokalemia as well. So hypoglycemia, hypokalemia are two huge things that you need to monitor for and be very aggressive about repleting up front. Additional adjuncts. So if someone has taken one of those sodium channel blocking beta blockers, as we talked about, propranolol is one of them, and you get sodium channel blockade that causes QRS widening, you should give sodium bicarbonate, right? Sodium channel blockade gives sodium bicarbonate, increase the sodium load to try to overcome that sodium channel blockade. So if there's QRS widening, you really should consider giving sodium bicarbonate, 1 to 2 milliequivalents per kilogram bolus. You can titrate it to a pH of 7.5, 7.55, or a QRS that has normalized. And this can be, again, life-saving. You should be very thoughtful about this. If you see QRS widening, that's going to be a risk factor for going to ventricular arrhythmias, so you should be aggressive with your sodium bicarbonate up front. Patients who seize, right, maybe they took a lipophilic beta blocker like propranolol or metoprolol or carvedilol. Benzodiazepines as therapy for seizures is certainly indicated. Some of these patients need to be intubated, propofol, all that kind of stuff. The big thing to note here is that normal anti-epileptic drugs are not very effective in these patients, and if someone has sodium channel blockade, you want to avoid them, especially phenytoin. So treat the seizures with GABAergic medications like benzodiazepines or barbiturates or propranolol, or propofol. Do not give them propranolol. And then avoid kind of those anti-epileptic drugs, phenytoin specifically. If a patient's having bronchospasm, remember we said beta-2 receptors that can cause bronchospasm. So inhaled beta agonists, all that good stuff can be helpful for bronchospastic patients. Not that we've seen a ton of these, but we have seen them, and they're always very, very sick. And bronchospasm isn't something that seems to anecdotally come up very often in these patients, but it certainly can happen. So be observant for it. Some of the other crazy tox stuff, lipid emulsion therapy for refractory shock from a lipophilic agent. So lipid emulsion therapy is literally you're giving intralipid into the bloodstream, and it's kind of these like lipid bubbles sort of. And if you have a beta blocker like propranolol that's lipophilic, the lipid emulsion will kind of surround that propranolol and not let it have any effects on receptors. So propranolol, carvedilol, metoprolol, all those are lipophilic agents. Consider lipid emulsion to treat them. And then if someone's in torsades from sotalol, management's kind of classical, right? Give magnesium. You can consider overdrive pacing, all that good stuff. So these are adjuncts for kind of specific scenarios. And the thoughtful thing here is it a sodium channel blocking beta blocker like propranolol? If so, is there QRS widening? If so, give sodium back, sodium bicarbonate. Are they seizing? Treat them with GABAergic medications. Avoid anti-epileptic drugs. Are they bronchospastic? Treat them for bronchospasm. Inhaled beta agonists. Is it a lipophilic agent like propranolol or carvedilol or metoprolol? Consider lipid emulsion. And then if they're in torsades because they took a bunch of sotalol, magnesium, which is classic. So patients, if they still continue failing these, right? You've tried everything. You've given them pressors and inotropes, and they've gotten their high dose insulin. Maybe you have even trialed glucagon. Maybe they even upfront got activated charcoal. You've given them sodium bicarbonate because it was a sodium channel blocking agent. You've given them lipid emulsion, and they still are failing. And there will be patients, if you practice in a place that's pretty busy with a lot going on and you do it long enough, there will be patients with beta blocker toxicity who fail all of these management therapies because it is such a deadly toxidrome if you take a lot of it. And if that's the case, you have to start thinking about rescue. How can we potentially rescue these patients? You've tried all the tips and tricks. You've been aggressive up front. You should be aggressive up front in big overdoses. Don't be reactionary. Be proactive. Get them on these aggressive therapies early, because if you're reactionary, there's going to be a lot of end organ injury that you're not preventing. Okay, so some of the rescue therapies. Obviously, you can try transvenous pacing for refractory bradycardia, but this sometimes doesn't work because sometimes their heart won't respond to it. So it can be unreliable, but you can try it. The big thing here is VA ECMO, veno-arterial extracorporeal membrane oxygenation. We've done some episodes on VA ECMO as well. Check them out. You can just search Whiteboard Medicine ECMO. That'll probably get it to you. And this is really what can be life-saving for these patients, right? Put them on VA ECMO, let their toxidrome pass, and they will get better. So don't delay this. If you're having trouble managing this patient, they're in fluid cardiogenic shock, you've trying all the things and they're not working. If you're not an ECMO center, get them to an ECMO center. If you are an ECMO center, let your team know. Let the ECMO team know that this might be a patient that needs to be cannulated. Every once in a while, what they took was a dialysable agent. These are ones like atenolol, nadolol, sodalol. So it's not a lot of them, and it's not the most common ones. But if it is a dialysable agent, you can obviously do hemodialysis to try to dialyze it off. This is not effective for propranolol. It's not super effective for many of the beta blockers. It might be somewhat effective for some of them, more effective for others, but it's not really effective for propranolol and some of the other ones. So you can certainly try this, but it might help you, it might not. So monitoring and course. For moderate severe ingestions and all extended release ingestions, just because you don't know how they're going to behave, they should really be admitted to the intensive care unit. These patients, again, aggressive early, right? Trend their lactates, trend their end organ perfusion markers like creatinine and LFTs and troponin and lactic acid. Put an A-line in them, have a central line if you need it. If you're doing high-dose insulin therapy, be checking those glucoses frequently, every 15, 30 minutes, at least every hour. Watch that potassium, serial EKGs, telemetry monitoring, all that good stuff, and really be aggressive up front with these patients. Get ahead of it rather than reacting to decompensations. Prognosis, if you recognize early and you intervene aggressively, there can be some favorable prognosis. Obviously, this is to a degree. If you take too much and you're not in an ECMO center, you might not be able to keep up. But early recognition and early aggressive intervention is key. There are some poor prognostic indicators, as with anything: refractory hypotension, rising lactate, rising acidosis, recurrent dysrhythmias, need for ECMO. All these things suggest a poor prognosis, which probably isn't surprising to anyone. All right, we're getting towards the end here. Here's a quick reference, and we'll do a couple practice questions. Quick reference, especially for test questions and maybe even in the clinical arena. If you're unknown if it's beta blocker, calcium channel blocker overdose, look to the glucose. Beta blockers have hypoglycemia. Calcium channel blockers have hypercalcemia. Sorry, glycemia. Hypoglycemia for beta blockers, hyperglycemia for calcium channel blockers. First line therapy, ABCs, right? Classic emergency medicine teaching. If it's early, you can consider activated charcoal. You can consider glucagon, use your pressors. And if they're even showing borderline signs of malperfusion, start high intensity euglycemic, high insulin euglycemic therapy early on, and really titrate it. Watch those glucoses, watch those potassiums. If it's a sodium channel blocking agent, or if you don't even know if it is and the QRS is wide, give them sodium bicarbonate. If they go into torsades, give them magnesium. Consider overdrive pacing. If it's a lipophilic agent or even refractory shock, give them a lipid emulsion. And if you're having trouble keeping up despite this, ECMO. Okay. And always, we cannot say it enough, call your poison center. They will be a hugely helpful resource to you. All right, into a couple practice questions. For those of you who have seen episodes before, you know that we'll read the question, read the answers, and pause quick, and then go read the question, read the possible answers, and then pause quick, and then go into the actual answer. So if you need more time to think about it, just pause the episode, because we'll go into the answer pretty quick. So first question is a beginner question. 27-year-old woman presents 1 hour after ingesting an unknown number of metoprolol tablets following an argument. She's somnolent with a blood pressure of 80/45, heart rate's 38, glucose is 52, SpO2 is 98% on room air. Her electrocardiogram shows sinus bradycardia with a narrow QRS. After securing IV access and giving dextrose, the best next step is to A, start a glucagon bolus, B, administer IV calcium only, C, immediate transvenous pacing as the only therapy, or D, give naloxone and observe. All right, answer is A. So glucagon is a first-line pharmacotherapy for beta blocker overdose. You often are able to improve heart rate and blood pressure a bit. Calcium alone is not effective. Pacing alone is not effective, and naloxone doesn't really address the beta blocker overdose. So next step you would immediately do would be consider glucagon therapy in this patient. Next question, intermediate difficulty. 35-year-old man has a propranolol overdose. Empty 80 milligram extended release bottle found. He's confused. He seizes. His blood pressure is 75/40. Heart rate is 30. Electrocardiogram has a QRS of 160. After airway control and benzodiazepines, which single intervention is most appropriate now? A, give magnesium for torsades. Friendly reminder, they weren't in torsades. B, give sodium bicarbonate bolus and begin epinephrine. C, begin a diltiazem infusion. Hopefully no one chooses that one. D, start hemodialysis. All right, answer is B. Give sodium bicarbonate bolus and then begin epinephrine. So remember, propranolol has sodium channel blocking effects, which means that it'll cause QRS widening, and you treat that with sodium bicarbonate. Give it till the pH is 7.5, 7.55, or narrow QRS. This patient also has hypotension and bradycardia, so epinephrine, right? Epinephrine has both beta effects and alpha effects. Great drug for this toxidrome. So start epinephrine. It gives you some inotropy, some chronotropy, some vasoconstriction. Other options, magnesiums to treat torsades. This patient's not in torsades. Diltiazem would kill this patient. That'd be horrible. Propranolol is not dialyzable. Okay, and remember the patient sees because propranolol is also lipophilic, so crosses the blood-brain barrier and gets into the brain. So other things you can consider here would be intralipid, right? Would be the other thing to consider. But the next step would be sodium bicarbonate and epinephrine. All right, advanced, last question. 62-year-old with ESRD ingests a large amount of atenolol. 12 hours later, he remains hypotensive and bradycardic despite fluids, glucagon, epinephrine, high-dose insulin, calcium, lactate 7, pH of 7.24. What's the best next step? A, discontinue insulin due to acidosis. B, start hemodialysis while continuing high-dose insulin and pressors. C, administer lipid emulsion. D, add a third vasopressor and wait. This one's a little bit tougher. Answer is B. Start hemodialysis while continuing high-intensity insulin therapy and pressors. So atenolol is hydrophilic, it's low protein bound, and as such it is dialyzable. So hemodialysis will remove the drug, improve the hemodynamics. You obviously want to continue the insulin and pressors during dialysis till they're doing better. Lipid emulsion is more helpful for lipophilic agents like propranolol and carvedilol, rather than this agent being atenolol. And then stopping insulin and passively adding pressors without source control or any of that kind of stuff doesn't seem like the right thing. So dialyze patients who took a beta blocker that is dialyzable. All right, that's all we have for you today. We appreciate you checking it out. Let us know what thoughts, comments, questions you have. Check out our Patreon page, our YouTube or podcast, depending on what you're listening or watching this on. And then we have a newsletter too that we may crank up and be more active on, although our big focus right now is our YouTube, podcast, and Patreon page. So we'd love to see you on any of those platforms. And either way, stay well, keep learning. We'll see you next time.